This chapter discusses the different methods that are used to provide therapy for patients with various psychological disorders. So, we're going to start off with how the field has treated psychological disorders. This should be somewhat of a review from previous chapters. You'll see some familiar faces reappear again because there were no treatments for some of these disorders that we know for a fact have a very strong um, neurological and neurochemical basis. For example, schizophrenia definitely is one of those disorders that talking therapy is not enough to treat the condition with. So we need, and during earlier times, there were no medication per se or effective medication. So the efforts to treat psychological disorders were really cruel and based on irrational beliefs. If the belief was that the devil was possessing the person's mind, then they would have treatments where they bled the folks to death or bled them. And many of them died, unfortunately. So the idea was if the devil is in the blood, let's get the bad blood out and hopefully the body can make good blood in. They had leeches. You saw trephination, which was putting hole in the skull of the afflicted person. So we have all these really irrational treatments and cruel. This chair was, just to give you an idea, was one of the treatments. I want you to pay attention to what they were trying to do is deprive the individual of any sensory input. And the idea was that would cure their psychological disorders, whatever it may be. Now, if you look right here, they would put a bucket for the person because they would be sitting there for hours at a time. Really cruel ways, and you can imagine it didn't work. This was hypnosis where they would hypnotize and hopefully the devil would come out of the person. Really bizarre ways to treat. Some of your early reformers, so Philip Penel, if you remember, in France, started the conversation about treating psychological disorders as a medical issue. So he would go to these asylums and free the individuals to walk around. You should remember this from Psychological Disorders chapter. So please make sure you mark down Philip Penel. Another reformer in the United States was Dorothy Dix. This is her. Dorothy Dix was a school teacher who, after retirement, became really interested in patients with psychological disorders. And of course, what she noticed, many of them were women. So she would go into these asylums, these really prisons, for lack of a better word, and would help these patients get them out of the asylum, and would take them to these treatment centers, which were basically just away in the wilderness, not in the wilderness, but somewhere calm where they could take serene walks, and some of the patients got better. So the idea of the mental hospitals came from these treatment centers. And we're going to look at the history of what happened to these mental hospitals. Since 1950s, mental hospitals have been emptying because of the newer and better treatments, such as psychotropic treatment. So these are some of the things we will look at as we progress through this chapter. But make sure you take mark of Dorothy Dix. Today we have two large umbrellas of therapy that quite often will complement one another. Psychotherapies, we're going to start off with the different methods of psychotherapy. These are what we call talk therapy, where the patient comes in and sees a trained therapist and tries to come up with coping mechanism depending on which method of therapy you're using, and we'll go through that. Before I would say 80s, late 80s, early 90s, most therapists were trained in one of the modalities or therapy techniques that we're going to talk about today. What happened with insurance companies is that they came up with managed care, meaning we are not going to pay for your psychotherapy for years and years and years. We will give you limited number of therapy. And what that did for the graduate schools is that they began to train these therapists to become eclectic in their approach. So today, if you go to graduate school, many of the graduate schools are training their therapists to not only provide, let's say, psychodynamic form of therapy, but they train them in the different modalities. So that a therapist today probably is way better than the therapist we had prior, because they have a blend of therapy techniques. They have taught it. The next umbrella, which we'll end the class with, are biomedical therapies. These are medication that quite often will be coupled with psychotherapy, so that the patient is taking medication at the same time or going to therapy in order to provide them with possibly some social skills that they may be lacking. And then we'll talk about the most drastic, which is medical procedures, and we'll take a look at the historical approach to medical procedures. So there are many different modalities to psychotherapy or talk therapy. The ones we're going to concentrate today on are these the most influential types of psychotherapy. We're going to start off with psychodynamic, which we call psychodynamic, and move down the line. For all of these, make sure you know who the founders are and the basic premise, meaning the basic belief about what psychological disorders are caused by, and thus how we need to treat the patient. And we'll go through these again as we progress. Most of these therapies that are here can be found one-on-one, so you go see a therapist by yourself. They can also be used in a group setting, which insurance companies absolutely love. And we'll talk about both of these modalities. Not so much about groups in our class, but if you get a chance, if you're a psych major, in graduate school, you will definitely learn about different modes of therapy. But even on undergraduate, sometimes they have introduction to counseling or introduction to therapy classes. So you might want to look at that. So the first form of therapy was developed by Sigmund Freud. Freud believed in talk therapy in revealing or unmasking one's unconscious wishes. If you remember from the personality chapter, he believed that it is these unconscious thoughts that are ultimately make us behave in certain ways. So sometimes we don't even know why we behave the way we do. And that is solely because of those unresolved, anxiety-provoking experiences in the past that are shaping our behavior. So in order to get control of one's behavior, and really for him, was the knowledge. If you know why you do the things you do, then behavioral change will follow. So Freud was the original developer of talk therapy. And he came up with psychoanalysis. Unfortunately, psychoanalysis is not practiced today in the United States. In order to do psychoanalysis, one has to be in therapy for years. And I'm not talking 1 or 2 years, I'm talking 10, 15 years, where the patient goes between 2 to 3 times a week for an hour each session and slowly unmasks what's in the unconscious. Although this is not practiced, psychoanalysis is not practiced, it does provide the foundation for treating psychological disorders. People came after Freud, got some ideas from his type of therapy, and really expanded on it and modified it to the different forms of therapy we have today. If you are looking, if you look at this comic strip that I put, this is what a psychoanalysis session looks like. The patient will be faced away from the psychotherapist in order to reveal all their unconscious thoughts. At least that's what the goal is. Please make sure you know the goals of psychoanalysis. The ultimate goal of psychoanalysis is 1, to bring the patient's repressed, disowned feeling into conscious awareness. And once you are aware of why you do the things you do, once you gain insight into the original reason for their disorder. It helps them take responsibility for their own growth. Well, this is fantastic, except it didn't work out that way. So if you know why you get into relationships with, let's say, abusive men or women, then you would change that behavior. You would look for healthier relationships. There's a lot of controversy with psychoanalysis. You can imagine how many of you, obviously this is not going to be a two-way conversation, but how many of you know that drinking soda is not good for you, or eating late at night is not really good for you? But yet many of us still engage in those unhealthy practices. So we know insight is not enough for behavioral change, but that was at the basis of his therapy technique. Some of the techniques that's used in psychoanalysis, and the ones you need to know for the exam, is free association was really the main technique. In free association, the person talks about whatever comes to mind. Free associating, right? And the goal is that as you free associate, somehow the unconscious will be revealed. So if you go to a psychoanalysis session, the therapist will not lead the session, meaning they sit back and allow you to talk about whatever comes to mind. If you ask questions from your psychoanalysis, they will not answer any personal questions. One of the reasons for this is that they're hoping the patient will, you don't need to know this for the exam, but it's an important aspect in psychoanalysis, that the therapist will be a blank slate, meaning you don't see the therapist as a person who maybe have a life of their own, but will be a blank slate for you to project all your emotions about your father or mother or anyone that you have a issue with in life. You can project that, transfer those feelings to the analyst, and thus work through that relationship. So that's one of the reasons in psychoanalysis, the therapist will not reveal any personal information. So as the patient talks more and more about their, and freely free associating about their personal personal childhood experiences and anxiety-provoking thoughts, what you find, and a lot of psychoanalysts will kind of vouch for this, the patient, as they uncover these anxiety-laden material, they will begin to get anxious and may resist. You don't need to know this for the exam, but will show you resistance. Resistance may take the form of the patient saying, I just don't have any more money for therapy, I'm going to quit. Or coming to therapy late, or not wanting to talk. All of these are telling the therapist that the patient is uncovering some painful stuff and that they need to kind of push the patient to reveal and unveil these anxiety-provoking material. So the job of the psychoanalyst is to interpret and provide the patient with insight. A true psychoanalyst will never tell you what to do. They will kind of put the question back to you and help you interpret these events that may have affected your life. Unfortunately, again, psychoanalysis, because no insurance company will pay for a patient to go to psychoanalysis 3 times a week for 12 years, is not being practiced. There are some psychoanalysts still practicing today. Those patients are paying, obviously you can imagine they're pretty wealthy. They have to pay out of pocket, and a lot of the reasons, a lot of insurance companies will not pay for it. They will tell you there's no underlying theory. This underlying theory that things are in the unconscious are not supported by scientific research. Well, it's really difficult to know what is in the unconscious if the person's not aware of it. So there's not good research supporting the efficacy of psychoanalysis. Interpretation cannot be proven or disproven, unfortunately. And most importantly, and ultimately it's all about money. It can take years of several expensive sessions per week to see any behavioral change, if you do see it. So what we have today, we don't want to get rid of psychoanalysis at all. what the field has done is make a contemporary version of psychoanalysis. And today we call this psychodynamic therapies. Make sure you know that for the exam. So what used to be called psychoanalysis in the United States today is called psychodynamic therapies. Psychodynamic therapies are fundamentally different than psychoanalysis in certain aspects, but very similar in the way they believe psychological disorders have come from are very similar. So they do help. They believe psychodynamic therapies believe a lot of the disorders that we have are have originated from our childhood experiences, very similar to psychoanalysis, and that it is essential for the therapist to have this blank relationship with their patient. However, if you notice, this is a psychodynamic therapy. You are facing your patient when the patient comes in. Because you have a shorter time frame than the traditional psychoanalysis, the managed care company will tell you you only have, let's say, 6 or 10 sessions to deal with this patient's obsessive compulsive disorder. So if you have, let's say, 10 sessions, you will concentrate on the person's childhood experiences that are related to their symptoms, rather than just talking about childhood experiences in general. So it is much more directed, therapist-directed sessions, and the therapist is actively involved in the session. Again, very different than psychoanalytic therapy. Your next big class of or big group of therapy are humanistic therapists. These folks, again, are very different than psychoanalytic in a lot of reasons. Please make sure you know the aim. Humanistic therapy are one of the ones that do not believe in illness model. They will, they will not diagnose you. A true humanistic therapist will not diagnose you. They just believe that these are symptoms that are keeping the individual from growth, and the focus is on promoting growth. So their aim is to boost the patient's self-fulfillment by having them know about themselves and accept who they are. So if you remember again from personality chapter, their goal is to overlap the real self with the ideal self. So and they really came as a reaction to humanistic therapies. What I want to make sure you know for the exam are these last two. I mean, obviously you need to know the other ones, but these two are really important in distinguishing this type of therapy from all the other ones. One, they believe in conscious thought. They don't want to know about your unconscious, so they want to know, what do you think about yourself right now, and what do you think you should be? So again, they're constantly in conversation with you. They will not ask you about your past. It's the present that is important. So they're asking about your conscious thoughts now. And the goal is by changing the present, by having you be present and really know who you are, that your future will change. So present and future is much more important than the past. So there are different types of humanistic therapies. One of the original one was developed by Carl Rogers. You got to know this for the exam. Carl Rogers came up with client-centered therapy. Here's Carl Rogers. His belief was that when a patient comes to you, because they didn't get that unconditional positive regard from their loved ones, from their caregivers when they were kids, they separated their real self from the ideal self, and thus are having psychological issues because of that. So what we need to do is provide that unconditional positive regard in therapy, and that is provided through the therapist. So the therapist's job is to actively listen to their patients. They have to listen with a genuine and accepting and empathic environment, so that the patient can be who they want to be. Now, there is some controversy with client-centered therapy, because if you don't like your patient, if you can't empathize with their flight. So if a patient comes to you and says, I'm having a hard time, I'm a neurosurgeon and I really want to be a carpenter, if you have a problem with that, unfortunately, the issue, you're not going to provide that empathic environment for your patient. So it's really important to get to know yourself. Most therapists that are client-centered therapists really know about themselves, their limitations, so they know what type of patients they can and cannot work with. You don't need to know these for the exam, but this is usually what happens in humanistic therapy sessions. Because the therapist is actively listening to what you're saying. They quite often will summarize what you have said and repeat it back to you. Sometimes we don't realize what we're saying. If it doesn't make sense, they will ask for you to give an example or provide you with clarification. And most importantly, they will reflect the emotion back to you. So these are some of the techniques that are used by humanistic psychology. I'm just going to go back for a second. Humanistic psychology is a fantastic type of therapy if the individuals is facing life decisions. Should I study psychology or sociology, or should I do this or that? They're really good about providing clarity for the individual. It will really help you get to know what you truly want to do. It is difficult to find humanistic therapists today, though. Most of your therapists, because insurance companies love behavioral therapies and cognitive behavioral therapies, we see a lot of this mode practiced. So if you remember, behavioral therapy is all about eliminating unwanted behavior. These folks do not care about self-awareness, the unconscious, yourself. This is, what behavior do you want to get rid of, and let's do it. So much more behaviorally oriented. So for behavior therapists, it's not here, but please mark down, if you remember, John B. Watson is one of your original behavioral therapists. John B. Watson with classical conditioning. You want to know that for the exam. John B. Watson with classical conditioning. And B.F. Skinner with operant conditioning. So if you remember, John B. Watson talked about associations, right? He did the little Albert experiment and helped us understand our emotional association with certain things can bring about certain behaviors, phobias. So O.H. Moorer came up with treatment for bedwetting, and he used the basic concept of classical conditioning, which is association. So what he came up with is these pads, these liquid sensitive pads. He connected it to alarm. So what you would do is you would put, for children who 5 and up were bedwetters, you would put these pads underneath their butt where they slept, and the minute urine hit, there would be some kind of alarm. They used electric shock and other kinds of really loud alarms to wake the person up. So what we know is, and there's a lot of truth to this, when the child is in deep sleep, their body is relaxing so that it doesn't help the brain wake up from, as urine is filling up, the bladder relaxes and you urinate. It doesn't allow the brain to wake up so you can use the bathroom, or at least hold on until you come out of that deep sleep. So what the bedwetting, this sensitive alarm pad does is associate the bladder with the brain, so that the brain associates, if I bedwet, I'm going to get this shock, so that it wakes itself up before urination happens, and it works really well. So one of the techniques that was used therapeutically through classical conditioning, or what we call associations. You have these other type of therapies called counter conditioning. Counter conditioning means the learning is going to be countered, or you're going to relearn in a more productive way. Now, what we do, unfortunately, in class, and since we're not there, I'm going to write it. There is a therapy. It's not counter conditioning. It was kind of counter conditioning called flooding. You got to know that for the exam, right? So in flooding, really bad handwriting. Here you go. In flooding, the individual has you are, and this is a definition, make sure you mark it down, and if you don't get it, you can just kind of rewind it. Flooding is exposing, type of exposure therapy, exposing the patient to the feared object in full force. So what it basically is saying is you are exposed, let's say you're afraid of spiders. In flooding, they would put you in a room filled with spiders so that once you realize that you're not going to die from being in this room with spiders, the fear will subside and the individual would be cured. We can imagine there's a lot wrong with this. What they have found before flooding is very effective. And I will try to put this this video that I have. It doesn't work really well with Screenomatic, but this woman who has fear of snakes, I will put up the video where they have used systematic flooding in helping her overcome the fear, and it works. And most of the time when we fear objects or situations, we run away from it. So if let's say I fear a snake, I see a snake, I run the other way. Well, I just confirmed how awful the snake is, right? By running away from it. If I can sit down, this is what they find, obviously a non-poisonous snake, but if I can sit with a snake, or if a snake is in a cage and I can sit and tolerate that fear, that over time I will learn I will not die from being that close to a snake, and I may that fear will begin to subside. So this is flooding, which is one form of exposure therapy. The problem with flooding is if the person suffers from panic attacks with the fear, they may have a panic attack and pass out, which will actually more likely confirm the fear, and they will get worse over time. If they have any kind of heart condition, you don't want to do that. If they faint. So there are certain physiological assessment that needs to occur before flooding takes place. Some of your other exposure therapies, and you got to know these for the exam, they are quite often used again with fears and anxiety provoking situations that we avoid. Systematic desensitization is one form of exposure therapy, which is very mild. You let's say in this form of therapy, you're associating a relaxed state, and what you're doing is you're gradually increasing the anxiety triggering stimuli for the person. So I'll explain what that is. Let's say someone fears mice, right? So they will sit down, the therapist will sit down with the patient and ask them, what is the most terrifying scenario with a mice that where you would never ever deal with it? It increases anxiety for you to really uncomfortable level. So the patient might say, if I am sitting with if I have a mouse on my leg, that's the worst situation, right? So they put that as a 10. What situation would you be willing to expose yourself where it produces anxiety, but you think you can tolerate? And the person might say, well, I think I can, if there was a picture of a mouse in front of me, I think I can tolerate it, right? So what they would do is bring up the picture of a mouse and provide you with systematic relaxation. So they would help you relax and calm down until you can tolerate looking at a picture. And then they would kind of gradually increase it. Maybe we can have a mouse 10 feet away from you in a cage, right? in a glass cage where you know they wouldn't get out, and systematically desensitize you, kind of help you relax, and slowly work up to putting that mouse on your lap. Oh, sorry. It tends to be much more tolerable for individuals. Virtual reality, I'm not going to ask you this, but this is because of our ability, modern technology. Let's say someone is petrified of flying, they can slowly expose them to their greatest fear, so that the individual, they may talk about, walk into the airport and relaxing them. Ultimately, they may, instead of flying with them, they virtually put you in that situation and help you tolerate it. So this is a video. Unfortunately, it doesn't work. But I will put it up as a supplemental video. Make sure you watch it. Another form of therapy is aversive conditioning. If you remember this from learning, again, classical conditioning, if the patient, and this is used for alcoholics, and I'm going to put the drug that we talked about in class. Again, you need to know this for the exam. For alcoholics, the goal is to give them a drug called antabuse, right? Antabuse, if the individual takes antabuse and the minute it goes into your system, if they drink alcohol, they become profusely sick. So that the goal is you take a neutral stimulus, an unconditioned stimulus, which is the drug, that will make you nauseous. Now you're going to take a neutral stimulus, which is the alcohol. And the minute alcohol is combined with that antabuse in your system, the person will become nauseous. The goal is ultimately, because every time you drink, you will become nauseous, the taste of alcohol will be associated with that unpleasant state, and the person will stop drinking. Again, not the most effective treatment. For some folks, it works. For others, it doesn't. But no antabuse as an aversive conditioning method for alcoholics. Operant conditioning, which was started by B.F. Skinner, is quite often used as a behavior modification technique. In this type of technique, you are reinforcing behaviors that you want to increase, and either not reinforcing or punishing the undesirable behaviors. Quite often used with a developmentally delayed, autistic, and other type of problems with behavioral issues with children. One of the most common type of techniques under operant conditioning is this token economy. Some of you may have been on token economy as kids and not know it, but this is where people earn a token, and this is usually children, earn a token for a desirable behavior, and can later exchange that token for privileges or treats. So for children who may be autistic, what they might do is every time you make eye contact, you earn a token. And at the end of the week, you can take all your tokens and trade it in for a game or whatever the child enjoys. And you can use this. It doesn't have to be for developmentally delayed or behavioral issues. You can even use it for just basic child rearing. The next category is cognitive therapies. If you remember, cognitive means thinking. So these type of therapies, please make sure you know this for the test. They're concentrating on more adaptive ways of thinking, and ultimately that will, if you change the way you think, that will affect how you act. So this is based on the assumption that your thoughts intervene to your emotions. So if you're always thinking negative thoughts, or if you let's say have really bad low self-esteem, and you just put yourself down even mentally, that will affect your self-esteem. So cognitive therapy's goal is to change the way we see our environment, the way we rethink our belief system. So these are the belief system that can be problematic, and we can change those and make it not problematic. So if you lose your job, those that have more internalized believe that it is something about them, they will, if they lose their job, they may say stuff like, I'm worthless, This is hopeless, what we quite often see with learned helplessness aspect of depression. And this, because you don't have, this is you a low self-esteem issue, or it's hopeless, things will never change, the person is more likely to suffer from depression. So those that suffer from depression, if you go to a cognitive therapist, what they will work with you is this internal belief, right? Instead of blaming you for everything, maybe we can find some alternative ways of interpreting. So someone that doesn't suffer from depression may say, my boss is a jerk, I deserve something better. Or even if you have done something wrong, they will work with you in attributing the loss not to something more internal, something about you, but something that you can ultimately change and have control over. So the therapist that you want to associate with cognitive therapy is Aaron Beck. He came up with cognitive therapy. Beck said, and if you ever get a chance to watch his therapy sessions, it's really fascinating. He's a really gentle man in seeking questions to kind of reveal these irrational thoughts, right? So he believes that if we take off these dark glasses, that, if someone says, no one loves me in my life, Beck would be the first one to kind of gently challenge that. So no one loves you. Do you have any friends? Well, I have one friend. Do they love you? Yes. So it's not like no one loves you. And then on slowly beginning to help the patient see the world from a more positive perspective. So for Beck's therapy session, many students become very anxious before an exam. We know that. And we know these negative self-talk can ultimately affect your exam's outcome. So the job of the therapist is to help you think about an alternative ways of looking at the exam, right? And to change that anxiety into a more positive force that can help you concentrate. So training people to talk back to these negative thoughts can be effective at curbing depression, anxiety, and such. Your next, so Albert Ellis, who you want to associate right here, Albert Ellis, you want to associate him with the founder of cognitive behavioral therapy. This guy came and said, listen, it's not enough to just work on cognition. We got to follow this through with behavioral change. So we got to combine both of them. And this has been a really effective method for disorders like OCD or even depression. So Ellis suggests that even when cognitive therapy works, right, when you change those thoughts, it may not be enough, right? So let's back it up with action. So what quite often happens in Albert Ellis's sessions is he will give you homework. So go to your, when you go to, let's say you take the exam, I want you to write down right after exam what your thoughts were. What did you think? How did that make you feel? And how did you behave? Then you come back to him and you show him your notebook, and he would go through and say, this is not what I want you to do. Can you see how, because you thought those negative thoughts, these things, your emotions were affected, and thus your behavior may have been affected. So let's change that. And he has you really working, well, I think he's passed away, but he had you working on changing this narrative from cognition, see how it changed your behavior, and the outcome will be different. Your next big group of portion of therapy is what we call group and family therapy. Anything more than two individuals who are not related are called group therapy, and family therapy, you can imagine, is about a family. Family therapy is super special. I want you to know this for the exam. If you are interested in providing therapy for patients, and if you're interested in working with children, you want to get trained in the different modalities of family therapy. Family therapy believes that when a patient comes to you, this happens, I remember providing therapy for kids, and this happened 9 out of 10, where the parents bring the kids and say, my kid has this, fix them, and would leave. These folks believe that the child's behavior is not exclusive to the child, but is more of a systematic problem. That means the way the family interacts is contributing to the individual's unwanted behavior. So if you go into family therapy, you will learn family therapy or family therapist will not identify the patient as an individual, but their patient is the family system altogether, right? They will treat the family in general. To just give you an example, what we quite often see is when parents have problems, they're having marital problems, it is not unusual for the child to behaviorally start acting out, because what happens is it takes the attention away from the adults' problems, and the adults unite in order to work with taking care of the child. So that in a way, the child is trying to save the parents' marriage by acting out. So, and we see this, and the only way that you can bring the child and work on their unwanted behavior, but is sending them back into a family dynamic that doesn't work. So if you can bring in the entire family and work through that, you will quite often find that most children's behavioral problems, unless they have ADHD or other issues, we're not talking about that, but just basic behavioral problems, originates in the family system dysfunction. So we talked about all these different methods of therapy. Is psychotherapy effective, right? Is one therapy session, therapy type better than the other? So there has been a lot of studies. The first study that came out, and you got to know this for the exam because it really shook the field. Eysenck in 1952 did this meta-analysis of all different types of therapies, and a control group who didn't get therapy. And what he showed was, this is the result of his research. He showed that with or without therapy, so if patients got therapy or didn't get therapy, about 2/3 of them showed improvement with time. And that really shook the field. Now you can imagine if you went to school for for 4 or 5 years, 6 years, $100,000 under to become a therapist in the hopes of helping people. And this guy comes out and says, it doesn't matter if people go to therapy or not go to therapy, about 2/3 of them will get better with time. You can imagine what that would do for individuals, right? For therapists. That basically means your therapy is bogus. So people really became upset. Other research was done, and what they showed was Eysenck's, the method, that his research method was flawed. That's not important. I mean, it is important because, thank God, it interested the field in really looking at therapy. Does therapy work using a research method that is more peer-reviewed and valid? So this is what National Institute of Mental Health did, this expansive study where they took a bunch of experienced therapists trained in different modalities, right? So we learned about cognitive therapy. We have another mode of therapy which falls really under psychodynamic called interpersonal therapy, and another group that was just given medication. They took a bunch of 239 depressed patients and randomly assigned them to either one of these or what we call a control group, which means they didn't get anything. And after 16 weeks, what they found was depression had lifted for more than half in each of the treatment, whether they went to cognitive, interpersonal, or drug therapy. And only 1/3 of those that did not get therapy improved. So that's a little bit better than the earlier data. And they have followed through with this therapy. And what they have found is patients that continued with therapy were in interpersonal or cognitive or drug therapy, that the rate of getting another episode of depression significantly decreased. So there is that benefit of therapies, so that therapy not only does it help patients in majority of the cases, it also makes it less likely for the condition to come back. So that's the good news, at least. What it did show was that and please make sure you know this for the exam, no one type of therapy is best across the board. So you can't say we looked at all these therapies and cognitive behavioral therapy is the best. That's not what research found. They did find there's some forms of therapies, and you don't need to know the specific behind this. Some form of therapy are really good for certain disorders, obsessive compulsive disorder, behavioral or cognitive behavioral therapy works really well. So there are certain phobias. Your behavioral therapy, counter conditioning may work better than psychodynamic therapy, but in general, no type of therapy works better than the other one. Folks, you might want to take a break if you haven't already. I'm going to cover, so you might want to put this on pause and take a break. But we're going to talk about the biomedical therapies. These are either using procedures or medication. So let's start off with medication, and please make sure you know this for the test. So in 1943, if you remember from earlier chapters, I'm just going to write this. 43. Albert Hofmann discovers LSD. Right? And what LSD showed was that you can make a drug. This is right here, right? You can make a drug that can make individuals hallucinate. Just unthought of. Unbelievable at that time. 1954. The first psychological, or what we call psychotropic medication, comes out, right? This was Thorazine, which is an antipsychotic. Not only did it help psychotic patients, but also patients that were maybe bipolar. It helped them control their emotions a little bit better. But before this point, right, there were no medications. So what you saw is individuals would come into these mental hospitals and would stay on really forever. Then 1954, this medication came, Thorazine, and in a matter of 2 to 4 weeks, you have patients that had been stuck in the hospital for years and years and years, were getting better enough to be released from the hospital. So they saw a surge of people coming into the mental hospital because they felt like there was a cure, and they began to see these mental hospitals, the population kind of lingering in the mental hospitals, begin to decrease because now we're giving medication and they're out. So a couple of things that you need to know about this slide, and unfortunately a lot of things happened here, which we'll talk about in a second. But LSD gave birth ultimately to your psychotropic medication. So make sure you know that for the exam. LSD gave birth to these drug therapies for psychiatric patients. Okay. You don't need to know this for the test, but one of the things you should be seeing, especially with this these new medications coming out, are double-blind studies. You want to make sure the medication doesn't have side effects and is proving treatment. You don't need to know any of these. So what you will find is there are different major classes of drugs that are ultimately helping patients with different disorders. So the first class of drugs is what we call antipsychotic drugs, and not surprisingly, antipsychotic medications are their aim is to treat psychotic disorders, with the majority of psychotic disorders falling under the category of a schizophrenia spectrum disorder. So these antipsychotic drugs are quite often given to schizophrenic or any other kind of thought disorder, severe thought disorder disorders. The first class, the original class of antipsychotic that came out, we call this typical antipsychotic. Make sure you know that for the exam, like Thorazine, Haldol. These medications decreased the level of dopamine or blocked dopamine for psychotic patients. And what they found was that they worked really well in treating positive symptoms of schizophrenia. So patients that were actively hallucinating would take these antipsychotic medication, and within weeks, really, their hallucination, paranoia, delusions were under control, and they could be released from hospitals. So please make sure you know typical antipsychotic, the first generation antipsychotic that came out, really targeted dopamine, and in decreasing dopamine, were able to treat these positive symptoms. Prognosis for typical antipsychotic medication is really good, meaning these medications are really effective in treating positive symptoms. Now, again, what's not here, and you need to know for the exam, unfortunately, these typical antipsychotic medication produced a group of motor condition called tardive. It's going to take me a while to write this. Tardive. There's an I. This will be on the test. Tardive dyskinesia is a motor dysfunction. It's a group of motor dysfunctions, and it's one of the side effects of typical antipsychotics. So for whatever reason, and I don't quite understand why, some patients that were taking these antipsychotic were showing these motor symptoms, twitches, puffing of the cheek, rolling of the tongue. If you get a chance, Google tardive dyskinesia, some of the symptoms, and you can see it on YouTube. They didn't know what was causing it. So patients who were on these antipsychotic medication and were showing tardive dyskinesia, these group of motor disorders, were given subsequent medication to control it, and it just got worse and worse and worse. And what they found was, when they realized it was the medication that was causing this disorder, when they took the patient off the medication, these antipsychotics, the patient continued to have these motor disorders. So it's an irreversible condition, unfortunately. It causes long-term damage. So what happens today if the patient begins to show these group of motor dysfunctions, rolling of the cheeks, twitches, they will immediately take them off the medication, because we know that's irreversible, and we'll switch them to another type of medication. Your second generation neuroleptics, we call these atypical antipsychotic. These are newer ones, and they are good, or they are used for patients who have positive as well as negative symptoms. So they are targeting dopamine as well as serotonin, those negative symptoms of schizophrenia. Now, when these medications work, they work well. Unfortunately, prognosis for negative symptoms is not great. meaning patients who suffer from negative symptoms, these medications are less likely to work than for typical antipsychotics for positive symptoms. So prognosis for those who suffer from positive and negative or negative symptom of antipsychotic is not great. Antipsychotic, none of these you really need to know, but antipsychotics are really have powerful side effects. They can make the individual feel really blah. They can make them not have affect. They can make them feel kind of numb. The newer generation antipsychotics are getting a bit better, but still we have a long way to go. So individuals who suffer from schizophrenia or other psychotic disorders are quite often encouraged not only to take the medication, but for the family to come in and get that kind of talk therapy, support therapy in helping the patient understand what they suffer from and help the patient kind of deal with their psychotic symptoms. Your next large group of medication are called anti-anxiety medication. These drugs, as you can imagine, are used to control anxiety and agitation. Anti-anxiety medication, the ones that work immediately, like Xanax, and some of the other ones that are given, what they do is they decrease central nervous system activity. They are really good at calming anxiety for the individual. However, what we have found with anti-anxiety medication, anxiety comes from the mind, right? So if we can control anxiety by having the individual change their thought order, it will work better in the long run than giving the individual medication. So again, these are great at reducing symptoms, but they may not resolve the issue for the individual. So really important to treat, if the person is on anti-anxiety medication, to couple that up with cognitive behavioral therapy or some form of therapy in helping them deal with the anxiety that's coming up. Sorry about that. We're going to skip that. That's not true. Anti-anxiety medication are one of the more profitable classes of medication, psychotropic medication, followed by antidepressants. Antidepressants are used for depressive symptoms. 75% improve with these medications. However, unfortunately, it says as 75% in placebos improved. There's a lot of controversy with that. Actually, the latest rate is about 50%. So patients improve 50% of the time even without medication, but there's problems with this research. It's not a well peer-reviewed research. What I want you to know here is this one. The best approach and the best result for depression is a combination of antidepressants with cognitive behavioral therapy. Your I went too fast. Your antidepressant medication, I don't know why, I thought I had a slide here. What you want to know about antidepressants, the most common class of antidepressants, I thought I missed one. I'm so sorry. Let me go back here. Your antidepressant drugs are treated for depression. They are sometimes used for anxiety disorders. They have found SSRIs, which is a class of antidepressants, work really well for disorders like OCD, your anxiety, generalized anxiety disorder. So there's a lot of research that's coming out as anti-SSRIs can be effective not just for depression but for other disorders. The one you want to know for the exam, if you go to a therapist or a psychiatrist, I should say, and it is determined that you suffer from some form of depressive disorder. They will, I'm so sorry, that was my dog. Hold on one second. Sorry about that. The first line of drugs that they will give are SSRIs if they don't have any family history, meaning if you have a family member that has taken another class and is a class of antidepressants, and there are many, then they will go for that. However, if they don't have any background information, they will go for SSRIs. SSRIs are really effective, have minimal side effects or less side effects, and are found to be effective for depression. Make sure you know this for the exam. SSRIs do not really fully take effect anywhere between 2 to 4 weeks. So what happened in late 80s and 90s, SSRIs came and they were applauded for being the cure for all diseases. So people would go to their therapist and say, I just can't go to the gym. I'm tired all the time. I think I have depression. And these therapists would give them these SSRIs. And the person would wake up the next day and say, this is like a miracle drug. I feel so much better. Well, this is what we call placebo effect, because we know these drugs don't start working until 2 to 4 weeks after taking. It takes a while for them to work. And the mechanism here is, if you remember from chapter 3, when we talked about these receptors that had retracted, had gone back. So normally the individual will release serotonin, and before it could activate the receptor, they would be taken back. So what SSRIs do is basically block the reuptake so that there's enough time for the serotonin to begin to affect the next neuron, and thus that pathway will be activated. Talked about this already, we can skip it. Your next large class of medication are called mood stabilizers. These are often used for bipolar disorders. So what we're doing is we're stabilizing one's mood, where that fluctuation from highs to the lows, we are bringing it down and stabilizing and flattening it. One of the, this is lithium, I misspelled it. Lithium is one of the oldest, and amazingly enough, they don't quite understand how this sucker is working, but is one of the oldest and most effective treatments for bipolar. However, lithium does have severe side effects. So if the individual is put on lithium, they are monitored on a monthly basis for the first 6 months, and they will slowly take them off. But you want to make sure that there's no lithium toxicity, because it can be dangerous. Depakote is another one. You don't need to know that one for the test. Lithium is the more common one. Then we have these more intrusive methods. One of them is called electroconvulsive therapy, or ECT, and this you all know as shock therapy. So please make sure you know ECT, electroconvulsive therapy, or shock therapy. And this is a biomedical therapy for severely depressed patients. Please make sure you know that for the exam. And what that means is, if you have given the patient the different classes of antidepressants, so you have given them SSRI, it doesn't work. You give them monoamine medication, what we call MOAs, inhibitors, and that doesn't work. And you give them all different classes of drugs. None of them work. Therapy is not working, and the patient is still severely depressed. Then you will try ECT, or electroconvulsive therapy. This is a last resort. ECT is where today it's safer than it used to be. I'll show you a video in a second where you can see how ECT may not have been the best form. Now they can kind of target what area they want to shock in activating those neurons to work. Usually one round of ECT tends to be effective, but some folks might need more than one, and it really jumpstarts the brain into becoming active. In the old days, ECT, because it was more pervasively used throughout the brain, it would cause memory loss. Does it still have side effects today? Yes, but way better than it used to be. You don't need to know any of these. These are, again, more intrusive ways of providing therapy for patients. This RTMS is one of the more interesting ones. This is UCLA is doing some great work. This is more superficial, where you take this wire coil that is giving out this magnetic ray, and it basically is activating the neurons in the cerebral cortex. So it doesn't really go deep in the brain like shock electric ECT, but it may be a useful method. There have been some studies that are showing some promising results. Unfortunately, they are still using some psychosurgeries today, although the rates are really, really low. Psychosurgeries before medication came out were commonly used, where you're removing part of the brain tissue used today for epileptic patients. One of the older forms of the psychosurgery was lobotomy, which is a psychosurgical procedure. And it was used prior for patients who were violent or uncontrollably emotional, what we would call today bipolar. And what they would do is they would cut the nerve connecting the frontal lobe to the more emotionally controlling centers, what we call the limbic system. So you probably may have heard of this. This is where they take an it's an icebreaker, right? This and they'll show you this in a second. And they would go through the eye and break through ice pick. Sorry, it's a sharp metal. They go through around the eyeball. They go through and with a hammer kind of break through the bone, the orbital bone, and go into the brain and move this rod back and forth. You may see some of it. You won't see the exact in this YouTube video, but it and what it showed was these patients became almost listless and lifeless. I'm going to show you this in a second, but what happened was Rosemary Kennedy, Robert Kennedy Jr.'s, Robert Kennedy, right? Yeah, the president's sister suffered from bipolar, and the parents took her to these hospitals, and a lobotomy was done on her, and she became this infantile, really almost delayed individual that would smile all the time, but she was never the same. And Robert Kennedy was really disturbed by the side effect, and thus today there is and really attempted to get rid of lobotomy altogether. So here's a really brief history. If you're interested, you can YouTube this and watch the entire program. Of course, it doesn't work, so if you give me a minute, I will put this up. The documentary is called The Lobotomist. I'm going to only show you, I think it's this one, about 5 minutes of it just to get an idea. The guy that popularized lobotomy was Walter Freeman, and he used it longer than he should.
He was an idealistic doctor, hungry for fame, who would champion one of the century's most infamous medical procedures.
He wanted to solve the problems of psychiatry, and he wanted to do it fast.
The lesson here is not how a man can go off the rails, but it's how science can go off the rails.
Ellen Ionesco was the first patient to undergo a procedure Dr. Freeman had perfected only weeks before. He called it transorbital lobotomy.
In a transorbital lobotomy, Freeman would first have the patient rendered unconscious through the use of the electroconvulsive shock machine.
Just before he threw the switch, we all had a laying on of hands and went for a little ride.
Usually three successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger.
The patient would then enter unconsciousness for a relatively brief period of several minutes.
Now this convulsion has subsided, the nurse holds a towel over the nose and mouth of the patient.
Freeman would peel back each eyelid
insert his ice pick and with a hammer, tap through the brain, wiggle it about, sever the frontal lobes, withdraw it. And when the patient came to, he or she would be given dark glasses to hide the black eyes they'd been given. We didn't have a refrigerator, we had an ice box. The first ice picks came right out of our kitchen drawer, and they worked like a charm.
Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy.
The instrument was put in above the eyeball and in the plane of the nose. You could feel it hit the roof of the orbit, and then with a tap of a hammer you could knock it through. The whole thing would take 3 or 4 minutes.
This patient came to the hospital this morning after breakfast, and we will leave tomorrow afternoon.
There are reports which he proudly writes down in his diary about fellow professionals fainting as he proceeds in this, or vomiting.
Dr. Watts didn't say anything. He simply turned around and walked out. Spurred on by Freeman, the number of lobotomies performed annually soared from 150 in 1945 to over 5,000 in 1949. Despite the known side effects, there seemed to be an endless supply of willing patients. Ultimately, the fate of lobotomy would be settled by a pill. In 1954, a new drug called Thorazine began to sweep through state mental hospitals.
Thorazine was initially marketed as a chemical lobotomy. This was seen as a selling point, that it produced results similar to lobotomy, but without, of course, all the risks of the surgery.
Freeman decided to move to Los Altos, California, to resurrect his career. Far from the reproachful Eastern medical establishment, he could try to bring lobotomy to new categories of patients.
If housewives found their early 1950s existence too depressing for words, why Freeman had a solution that would get them through their day, happy as little lambs. If children were misbehaving, conditions we might now see being called hyperactivity disorder, why they might need a lobotomy.
In all, Freeman lobotomized 19 children under the age of 18, including a 4-year-old. By 1967, Dr. Freeman had personally performed more than 2,900 lobotomies. In February, at Herrick Memorial Hospital in Berkeley, he performed his last when a patient died of a brain hemorrhage. Freeman was stripped of his hospital privileges and soon retired from his medical practice.
If you're interested, this is a really good documentary in showing a history of lobotomy, and it's much more expansive than what we just covered. So Rosemary Kennedy was one of the ones that suffered brain damage, really, from this disorder. Around the same time, Thorazine also came out. So Robert Kennedy goal was to get people out of these mental hospitals, treat them, and ultimately move them to a more community-based clinics, so that these patients, with a social worker monitoring them all the time and a psychiatrist, so you would have these clinics where patients could come, get their medication, get their social services met, and then not be in these mental hospitals. So unfortunately, a number of things happened, and that wasn't, his ultimate goal wasn't met, but that's what his idea was. So we know everything that is psychological is also biological, meaning your body can change with your mood. There's no question about that. There's more and more research showing this. Your bodies are designed for physical activities and social engagement. And we can see this. Levels of depression is going up because of the social distancing. So people are becoming really creative in the way they connect. Super important to keep exercising and connecting with others. We know exercise increases your serotonin, which will help with depression and anxiety. So all of these are important ways to take care of oneself. It's the mind and the body are ever so connected. Super important. This is just a quick comparison of all the therapies we talked about. And I believe that's it. Oh, there is the thing, you don't need to know this for the exam, but there is a buffer against stress in our lives called resilience. We know most adults have some form of resilience, meaning when we are faced with trauma or really harsh social or personal situations, that we can come out of that. Some folks, however, cannot overcome those challenges. And unfortunately, it is that lack of resilience that can cause post-traumatic growth and issues. So that's it for this chapter. I will put up the systematic flooding, systematic desensitization, which sounds like an oxymoron, but I will put that video up. Those of you that are scared of snakes or phobia of snakes, please don't watch it. Again, I will see you during Zoom for any questions you might have during this exam. For this chapter.